Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello and welcome back. This is Adam Rosen, and you're listening to the Total Knee Tips and Pearls podcast. In today's episode, I want to talk to you about the workup of the painful total knee. Now, this topic in of itself could be an entire weekend symposium, so there's no way I'm going to cover every single little thing, but I'm going to try to give you some important bullet points and maybe reinforce some things that are going to be really more important for you in the initial examination and workup and history taking of the patient, just to make sure that you don't miss the little subtle things. So like any patient evaluation and examination, one of the most important parts of that is taking a good history. So, obviously you want to ask, and I always get in the habit of not necessarily saying, what is your pain like or where is your pain, but what are your symptoms and where are your symptoms? Because people will point to different areas, and there's a lot to be gained from the person that takes their finger and points to one spot versus taking both hands and rubbing the entire knee or circling the entire knee because it goes all over or it moves. And also how they describe it. Is it sharp? Is it shooting? Does it come and go? You want to also find out whether or not that symptom is related to activity or rest. There's a big difference where someone has no pain at rest and pain with activity versus the person that says, no, when I'm moving, I feel great. I just get pain at night or when I'm sitting. The obvious startup pain, which everybody's been taught to ask for and look for signs of loosening. And then also what the range of motion is like. There's that difference between our perception of good range of motion and a patient's perception of stiffness versus someone that says, my knee's stiff, I can't bend it, and they really do have a lack of range of motion. They may give you that sense of instability, and especially this is important. Does it occur with stair climbing and getting out of a chair? You also want to know about their function. What are they doing? Are they limited with symptoms and they're doing basic daily activities? Or are they a high-impact knee abuser and they're getting symptoms with these higher than normal activities that may not necessarily be conducive to an artificial knee replacement? The other important thing with regards to the symptoms, though, is always asking, in correlation on the timeline. Were these symptoms present prior to the knee replacement? Are they new? Were they present right after surgery and have persisted, or were they not there and they had an interval of a pain-free total knee and now the symptoms are now new? That really helps kind of figure out, is this something that has changed or is this something that has been present? Because you always obviously want to check the joint above, check the hip. We always talk about you don't want to have somebody go through a total knee replacement and find out because they had mild arthritis on their knee x-ray, actually it was referred pain and they had severe hip arthritis as well as lumbar issues. You can have some lumbar problems and radiculopathy that could lead to quad weakness that could result in knee pain, even in someone that has mild knee arthritis, and a knee replacement is not going to fix that problem. And along with the history, obviously, you're going through the past surgical history. You're going through their allergies. Does this person have multiple allergies? Are they allergic to particular substances such as metal? Polymethyl methacrylate is an extremely rare but has been reported as an allergy. So there are other issues there. Were they using narcotics for whatever reason prior to surgery? Another issue that may lead to postoperative pain and poorer outcomes. So these are all important things that you want to do as far as asking, what the person is feeling, what they're going through, when these things have occurred, and then obviously what things they've done. So this kind of then goes back in a little bit more to the deeper history. Okay, let's go back to your day of surgery. Obviously, you want to get the exact date. And I make it a habit of, what was the date, if they can give it to you? Where was the hospital? What was the doctor, or who was the doctor? And that's important, especially if you're doing a revision for something that's, polyethylene exchange or some loosening from an old knee. If you don't know what the implant is, what you may find in your career is that if you know the doctor, even if they're now retired, and you can sort of isolate the doctor in the hospital, a lot of times the rep talk to the rep from that area, and we know exactly which company, which system they were using. So that can be really, really helpful. So knowing the doc, knowing the hospital, knowing the day of surgery. But I always ask, more detailed questions of how many days are you in the hospital, and was their hospital stay normal for the time period when they had their knee replacement? Did they go directly home? Did they have to go to a nursing rehab? Were they readmitted? Did they show up to an emergency room? And then other complications. Were there any drainage issues? Did they have a history of DVT or a PE? Did they require a transfusion? What was their physical therapy like? Did they give you the normal sort of, it was hard, I pushed through, or, worst thing in the world, I couldn't do it. And, that kind of gives you a different perception of what their postoperative recovery was like. And ask them, was their pain controlled? How many pills did they use? What kind of narcotics? How long were they on narcotics? Did they have any other procedures? Because sometimes people won't necessarily think of a manipulation under anesthesia as a surgery. So you really want to ask, did they have to take you back to an operating room? Did they have to bend your knee? And then what follow-ups? How many times did they see their doctor? Did they see the surgeon? Did they see a PA? When was the last follow-up? What did the doctor tell you? What did he recommend to you? And sometimes, you'll hear patients say, he recommended this, that, or the other thing, or thinks I need a revision, wanted me to see someone else first, or I didn't go back and see him, or he just told me everything was wrong. He gave me a good knee, and, I got to live with it. So you really want to kind of know what the patient's been doing, what they've been dealing with, and what things have been going on. So once you go through all of that information, the next thing that I try to do is gather some additional data. And a lot of times my staff will try to get patients to do this before they even show up for their initial consultation. But I want x-rays. And obviously you're going to get x-rays when the patient comes in. I'm talking about old x-rays. And I'm not talking about just after the surgery. I'm actually talking about before surgery, because we also know that patients that have more than 2 millimeters of joint space remaining on weight-bearing views prior to surgery may have more issues with pain and may have not as optimal of an outcome after a total knee. So if I see someone that's, severe, bone-on-bone arthritis and then a total knee, that already is starting to paint a different picture of, someone that gives me x-rays where the x-rays show just really mild arthritis and they went through a total knee. You also want to know, have they had a scope? Because again, some patients may not recognize that a scope is a surgery. They're thinking of bigger operations. So did they have an arthroscopy or multiple arthroscopies? Sometimes you can tell if someone had a bad fracture, if they have retained hardware based on the scars. Did they have injections? And if so, how many? And when were the last ones prior to surgery? You want to know about what was their function prior to the operation. So all of these things are really, really important to get an idea of what the patient was going through prior to the operation, what their symptoms were like, what conservative treatment options were utilized, and what their x-rays looked like prior to the operation. And then you can kind of get up to, okay, this is what your x-rays looked like. Now we've taken that history. Now we've looked at all of their old data. The op note is incredibly important if you can get it, especially if the op note is useful. You're going to get some op notes that are very cut and dry, 2 paragraphs, cut, implant. So you're not going to gain a whole lot of information from that, but hopefully you'll have the implants. So, we always make it a habit of, if you're dictating, look out for your fellow orthopedists. Obviously the implant record will be in the hospital, but make it a habit of, in your op note of having an implant section and the company, the implant, the sizes. So if someone has to do a revision down the road, they can either find the op note or the implant record, but you want to make it easy if the person's just doing an isolated poly exchange or a revision of one component. So now they're in the office, you've gotten your history, you've gone through their old records, and now we're going to do some new x-rays. And these are important because you may pick up some very important, obvious things. Obviously they have a fracture. That's a problem. Or there's gross loosening because there's implant change in position from prior x-rays. But the weight-bearing x-rays are important too, because occasionally you won't necessarily see this gross loosening or fracture line, but on a weight-bearing view, you start to see this slight shift in leg alignment and implant position, and they can have a fracture, an insufficiency fracture underneath the femoral component, which is subtle, and you get this subtle sort of change, and that can be a cause of pain, especially in the osteoporotic population or after a minor fall. So you want to look for that. But definitely getting new x-rays and comparing the x-rays is important to look for those obvious things. And then once they get done in the office, you're going to do a little bit more digging. Sometimes something pops up, you see a fracture, that's obvious. And sometimes somebody comes in with frank drainage for, weeks and months, obvious, it's infection. But so far, you're kind of getting down this road of, okay, these are your pains, these are your symptoms, this is what's going on, this is what it was like. Okay, we're going to have to do some more digging. So the next step is your lab. So you're going to get a sed rate and a CRP. The question is, how far do you want to dig initially, especially if they're not from your institution? Do you want to look at their chemistries? Do they have issues with anemia? White count, is it elevated? Do they have a low platelet count, which could be a cause of bleeding and hemarthrosis? Do they have diabetes? You want to check at A1C. Is it uncontrolled? Increases the risk for infection. Do they have severe renal disease, which increases the risk of complication? What is their albumin? Are they malnourished? So those are things that you may or may not decide to add to your initial labs, but things to consider, especially if they're from an outside institution, and especially if it looks like this is heading towards surgery, so you can start to get an idea of how much you may need to optimize this patient if they need an operation. Now, additional lab tests would be an aspiration. And again, this has been one of the things that has been talked about, written about, lectured about a lot in the past few years. And there's lots of options that you can do in your own personal lab, as well as companies where you can send out. And it really depends on what information you need, how quickly you need it, and what your institution or lab is like. Me personally, we've done pretty well in our lab. I don't necessarily send things out. I've tried things. I've tried Synovacure. I've tried the dipsticks, just to get an idea. But, we're pretty good with an aspiration, and, I send it off. I typically will write, no gram stain. Sometimes they do it. Why? Notoriously, gram stains are not useful. And unfortunately, there can be issues that if your lab does not necessarily strain their dye, they may incorrectly call some positive gram stains, which are actually just contaminant from clumping. But also with metal, if you have significant polyethylene wear and you're getting metal debris, occasionally those metal shards can be read as gram-negative rods. So I typically will write no gram stain. Occasionally it's done. I don't put a lot of utility in a gram stain. Even if it's positive, I kind of wait for a culture at that point. But we're looking at our leukocytes, and the number of leukocytes to really identify an infection over the years has continued to decrease, as well as people looking at PMNs. So depending on when you're listening to this and what study you're reading, I'm not going to go into specific numbers, but obviously the sensitivity and the specificity has been changing depending on what numbers you're looking for. But you want to look at your number of leukocytes and you want to look at your number of PMNs. Now, cultures are really important, and I always make it a habit of making sure that we hold cultures, the anaerobic cultures, for 14 days because, P. acnes may be one of those slow indolent infections which doesn't present with the robust red drainage that you might see with a MRSA infection or a strep infection. So making sure that you check it. And we're a big referral center, so I do out of habit send all of my cultures for aerobic, anaerobic, hold for 14 days, and fungus and AFB. And I haven't taken care of any TB in the knee, although my partner has, but I've had a few, candida infections and other weird infections. So I make it a habit of always sending it, for all of those things. Now, the other option is, what if you assume infection? What's the utility of PCR? We do a send out. We don't do that in our hospital currently. So we send it out to an outside lab in the Pacific Northwest. And it's great if it's negative. I've had issues where I've had patients that have had treatment elsewhere for infections and continue to have pain and with this concern or suspicion that they still have an infection. So if you do that lab test and send it back and it's negative, you can very reliably tell the patient, listen, infection's gone, infection's cured, your fluid was normal. However, that if there is dead bacteria in the knee, that occasionally it can come up positive. So just because it's positive doesn't mean it's an active infection. If you're in the midst of treating somebody, it may be dead bacteria that may have been amplified. But the aspiration is really important, especially the color, the look, and like any knee that's painful, not super common, but you always want to send it for crystals, because occasionally the painful red hot swollen knee can be gout or pseudo-gout. And the treatment obviously is very different than if they have an infection. So, looking at your labs and then making a decision on the aspiration. I commonly will wait to see an elevated sed rate or CRP in a non-draining, clinically non-appearing infected knee before I aspirate. However, if I have somebody that drove 4 hours to see me and they're here to really get their knee evaluated and they understand that, we could aspirate it at a second visit, but coming back and forth just for that is a big deal. I occasionally will aspirate it, because we have a unique sort of practice. But, if somebody's local, I'll always say, hey, let's get the labs, maybe getting another test or study, and then I'll have you come back and we can talk about an aspiration at that point. So what are the other studies that you can do? So other studies, obviously a bone scan. The bone scan can be positive and hot for up to 2 years. And I make sure that I tell my patients this prior to ordering that test if I'm concerned about loosening, because if the radiologist reading it is not aware of the day of surgery and they see uptake, they might conclude concern for loosening or implant is loose. Where if I let my patient know that, this is going to show activity because you recently had surgery, and the radiologist may read that as loose, they understand going in, and it saves you this big discussion after the fact. But if they've had recent surgery, I usually explain to them that, hey, listen, you're still having pain. No one's been able to figure out why. We're maybe concerned about loosening because I see a thin, lucent line in the cement. Or you had a press fit knee, we're probably going to get at least 2, because what I'm looking for in a bone scan in an early knee, 2 years out from surgery, is progressive worsening or progressive improvement. And I let the patients know that. Progressive worsening on the bone scan is probably indicative of loosening, whereas a progressive improvement is probably indicative of a normal postoperative change. Now, the other thing to keep in mind, especially in a late total knee, so this is 5-10 years out, if you see uptake around both components, really be suspicious of infection. Obviously you can get loosening of the femoral and tibial component, especially if there's massive osteolysis. Usually you'll see that on the x-ray if it's late and it's massive. But if you don't see these massive osteolytic cysts and lucent lines and implant change in position, and you see uptake on both sides, really be suspicious of infection and rule that out until proven otherwise. And like we talked about before with the history, figuring out where the symptoms are, I'll always ask about hip and leg and back symptoms, and you may want to get a hip x-ray because you can usually tell on an exam what the rotation's like, and if they jump when you rotate it, they got hip arthritis. But you want to check a hip x-ray just to confirm that there's nothing there that's going on. And then other special tests would be a CAT scan. The question is, what about rotation if that's in your differential of malrotation, malalignment? I personally, with these full-length CAT scans, haven't found that super helpful in my practice, looking at the femur and the ankle and the epicondylar axis and the components. Usually, I'm basing that more on my x-rays and my exam and looking how the knee rotates and functions. But there can be a lot of utility if you're getting CAT scans and you're concerned about that, about the rotation of the components. Now, other tests, if you're thinking infection, hard to prove with your labs and your aspirate. You have other leukocyte labeled indium type scans and Sirtex scans that may be the other extra tests that you can consider. So that's sort of your workup. So you have all this stuff, and then the other important thing is going to be your exam. And this is extremely important because I think more often than not, we tend to pigeonhole a diagnosis before we really hear the whole picture. You hear 1 or 2 sentences, or you see a lab or an x-ray, but you really want to make sure that you look at everything. So, this is the basics. You're looking at the knee. Does the knee look normal for a total knee? Does it look more swollen, more red, more inflamed? What is the alignment like? And I always start with having my patients just straighten and bend their knee, because it's interesting what you can tell just watching how somebody straightens their knee. Do they move it quickly or slowly? Do they guard it? Does it shake? Does it tremble? Especially if someone's sitting over the table and the leg is hanging off the table, and when they go to fire their quad, you watch it actually close down the flexion gap, engage before it extends. You haven't touched the patient. You already know their flexion gap's quite loose. You want to watch patellar tracking. And occasionally I'll see these weird rotational things. You kind of watch the foot, and you can watch it internally and externally rotated as it goes through an arc, which, sometimes to me indicates either an issue with rotation of the femoral tibial component or a mid-flexion instability type picture. But you can do a lot just watching them bend and straighten their knee a few times. And then obviously you want to check their strength throughout the entire leg. You check their neurologic function, check their vascular function, but then go through your exam. So, do they have full extension actively and passively? Because that quad weakness can be an issue. And then Do they have good flexion? What is their flexion? It's great if you can determine what their flexion was like before surgery, and is this better or worse? And also, what's their other like? Whether or not their other knee is replaced or not replaced, having some assessment of what their range of motion is like gives you an idea, especially when we're looking at either a super lax knee, which may have excessive flexion and instability, or a super tight knee, which may lack full range of motion. And then you want to check your ligamentous balancing. So, varus valgus, multiple points, but obviously an extension and mid-flexion. But be aware that if you have a knee that goes into hyperextension, you want to make sure that you're not testing varus valgus at hyperextension, but you have to flex it to neutral and making sure that.
We'll be back after a quick break.
Once a person is triggered, there are biological changes that happen in the brain that zap your energy, motivation, and sense of pleasure. Now, that in itself is not depression until people get into the depressive loop. It's very easy for people to stop doing things.
Yeah.
And you get into what we call an avoidance pattern of behavior. You stop doing things that give you a sense of mastery and a sense of pleasure, right? And you withdraw because the brain's basically like, hey, if you're not going to do this stuff, then I'm not going to give you the chemistry you need to want to do it.
Yeah.
So the less you do, the less you feel like doing. The less you feel like doing, the less you do. Now you're in the loop.
You're feeling true collaterals and not tenting of the capsule because they're in hyperextension. And then anterior posterior, whether or not it's a cruciate retaining, cruciate substituting, or posterior stabilized design is noting what that stability is like. And are they balanced? Are they not balanced? Is there some mismatch between the medial lateral sides or inflection or extension? And then watch them walk, watch their gait. Occasionally you'll see things that occur with the foot, the leg, the hip, the ankle that you don't necessarily perceive, at the table. So those are all sort of necessary and important things to do to help you in determining what your diagnosis is. So, all of that hopefully is the important information. Obviously, I can't go into every little detail of every little thing, but that really hits, I think, the bullet points of what you need to be thinking about and walking about, because there's a big differential. And that's where, I could probably do, an entire talk on each individual differential. But I want you to have all of these things in mind. So obviously the worst thing and the biggest thing we're always looking at in your differential is infection. So you're going to be ruling that out with obviously any sinus tract, fistula, chronic drainage, along with positive aspirate, positive cultures, elevated labs. So infection is the big thing that you're trying to use to rule out as far as your cause of the painful total knee. Loosening. And again, loosening can occur early or late. Early press fit knee didn't ingrow, early for whatever reason, poor cement technique, late due to cement failure, osteolysis, but loosening is the other big thing that you want to check for. Instability, which can be due to just simple polyethylene wear in a 20-year-old knee, and that's an easy polyethylene swap if everything else is okay. But the other instability, becomes, did they have a CR knee that was well balanced? They had a car accident, hit the dashboard, tore their PCL, and now they have instability due to that. Was there a collateral ligament injury? Did they have just progressive loosening and laxity over time, which I've seen most commonly in my patients in the guy who had a prior tibial plateau fracture, multiple operations, severely stiff. You go and do this big operation, get his range of motion. 2, 3, 4 years later, he comes back. He's got great range of motion, but now the collaterals, I believe, have elastically stretched back out to what it was like prior to his fracture and his stiffness prior to the knee replacement, and you wind up doing a polyethylene exchange. But you also want to know, did they change the joint line? Did they have some issue that give you a mismatch in flexion and extension? So you have to know where the problem is occurring before you decide on how to treat it. Do they have arthrofibrosis? Because there's that very different, I'm a painful total knee and my knee's stiff and they have 120 degrees of flexion, but they had 140 pre-op, versus I have a painful stiff knee and I can't bend my knee to 90. So, arthrofibrosis, again, is a cause for the painful knee, and knowing what your treatment options are available based on what you see and where they are in their time frame from their surgery is another cause of the painful total knee. Hip and back, again, don't forget it. I think we're all human. You kind of feel like you should pat yourself on the back as someone had a knee replacement and they keep having pain. You pick up that they have bad hip arthritis. But at the same time, here's a person that went through an unnecessary surgery essentially. And, you always want to check everybody's hips so you don't make that mistake ever. But occasionally people can have, knee pain in a totally normal functioning knee or total knee. And now over years they develop hip arthritis, but they think it's in their hip. So now you're fixing both problems. Metal allergy. And I bring this up, so this goes into the history taking. Again, it's a big unknown because even the dermatologist in the literature will say, even if you can prove that somebody has a dermatologic skin reaction to metal testing, it is hard to know and prove that person will also have an internal reaction to the metal. And then you get into the whole debate of all the different companies and options that are out there and available. And again, that's a whole nother podcast. Maybe we'll get into that at one point, but it's definitely something to consider because there may be some people that do react to some components, and that may be a cause of pain. The other thing that you want to look for is swelling. So painful swelling can be a cause of somebody presenting with a painful total knee. So do they have PVNS? Do they have chronic synovitis? Are they on medications for other conditions that may lead to an increased risk of bleeding? Do they have a clotting disorder? Some of those may be treatable, some of those not, but at least it gives you an answer to why they have this painful swollen knee. Superficial neuromas, not uncommon. So you want to look for, again, with the history, where is the symptom? Where is the location? What causes it? So that superficial, pain to the touch, neuroma-like response, maybe something that's correctable with an injection or a small surgery. So you want to look for where it is. Do they have pain due to an oversized component? Or maybe is it shifted medially or laterally and they're overhanging, or someone left cement and it's impinging on a collateral ligament or the IT band. So that's something that you can tell based, again, on the x-ray and then confirm with your physical examination. Is there an issue with malrotation? And this can occur both on the femoral or tibial side or both. Is there an issue with the patellofemoral joint, whether or not the patella was resurfaced or not? What is the thickness of the patella? Especially, this is important if you can get the preoperative x-rays. Was it cut flat? Was it cut asymmetric? Is there tilting? What was their pre-op x-ray? Did they have severe patellofemoral disease and had severe subluxation? All those are things that, you can look at now, but it's really important to know where that person came from and knowing, what's the difference, what's the change. And then also even posterior condylar offset and posterior slope. Someone that had minimal slope that now has a significant amount of posterior slope and is complaining of flexion instability, and there you go. There's the cause or the reason. Or someone that had a lot of posterior condylar offset that maybe somebody downsized or anteriorized, and now they've removed a lot of that posterior condylar offset is going to affect their flexion, affect their balancing. So you want to look for all those things. And lastly, probably the hardest thing is that your patient may be one of that 10 or 15 or 20% group of people that have pain after what we would consider a successful total knee. And you have to understand that that is a reality, and you have to have a good way of explaining that to patients. I never write people off. Sometimes you don't see something that is there that, it's worthwhile seeing them, a second or third time. And, depending on where you are, again, where I am, I'm sort of the end of the road. So I'm the last person that they're seeing after they've seen 2 or 3 other people. So I have to do the workup and I have to be complete and I have to look for everything. I can't just run one test or one x-ray and go, I don't see anything, you're on your own. But there are occasions where, I've done every test in every lab and we've repeated some of them and we've looked and we've seen them back. And, you can kind of tell people, listen, we've looked and we've ruled out A, B, C, D, E, F, and G. I don't see any of these things that are wrong. And, it's possible that you may just be one of those people that has some persistent pain and it may not be fixable and you may have to live with it. And then I think you run into 2 camps. You run into some people where those symptoms are mild. It's easy to describe that to a guy who had an MCL tear when he was in high school and has 2 staples and his pain's medial. And you can say, yeah, you had prior surgery and you had a prior injury and you have pain medially. And I explained, I can replace the ends of the bones. I can't replace your bone. I can't replace your tendon. I can't replace your ligaments. They're yours. Your skin's yours. The synovium's yours. And you may still have symptoms from all of those anatomic things, but whatever pain was coming from the bone rubbing on the bone, that's what we can fix, and that is what hopefully goes away. And if it was causing 100% of your pain, you're 100% pain-free. But if they still have symptoms, they may be one of these people that just has some persistent pain, even after, again, what we would call and consider a successful total knee. But you have to make sure that the patients understand that, and that you're not blowing them off and you're not telling them it's in their head, and that you've done everything that you can in your power. And occasionally, I've had those patients that still, the worst severe pain, and you can't find a cause. And, occasionally you offer the option of, hey, we can go in and take a look, or we can rip everything out and start all over again. And once in a blue moon, these are the patients that are almost disabled. And sometimes they get better and sometimes they don't. And sometimes we don't know what the cause was. Maybe there was something that was loose that you couldn't detect. And, maybe there was some instability that you couldn't detect, or some rotational thing that you couldn't detect. But that's definitely not for the faint of heart. I would definitely say that if you're going in to do an operation, 99.999% of the time, you really do need to know why and what you're doing and what you're going after. But there is reality, and occasionally there's things that we don't know, and under the right circumstances with informed consent, you can go in and do an exploration and occasionally revise things, and you may or may not fix the problem, and you may or may not determine what the problem is. It's nice when you go in there for you and the patient, when you can say, you know what, we worked everything up, couldn't figure it out, you couldn't live with it, we went in, and guess what? This was broken or that was off, and we fixed it, and you're better, and then everybody's happy. And then hopefully at the end of the day, all your patients are doing well. So I hope that gives you some food for thought and things to think about. It's sort of a little algorithm. There's great articles and algorithms, and you'll see this more and more at all of the meetings about infection and the painful total knee and loosening. So really in your head, as you start to go into practice, really start to create an algorithm, a template for you and your staff of, these are the things I order, this is what I do, this is the sequence that we do it in. And, important that your staff says, okay, these are the things that doctor needs when you come to see him for your consult for the second opinion for the painful total knee. Bring A, B, C, D, and E. And when they walk in the door, this way you have all that information to give you a good, thorough history of where this patient is coming from, in the hopes that you can determine the cause of the pain and help them. So thanks for listening. You've been listening to the Total Knee Tips and Pearls podcast. I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.